Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues and PGs, we are discussing pregnancy-related liver diseases. In the last vlog, we discussed the physiological changes in the liver functions during pregnancy. And then we enlisted 6 conditions that these are the pregnancy-related liver diseases. Today, we shall discuss the first case history and see what's the diagnosis, how to proceed, and how to treat that conditions. So let's go to the first case history. The first case history of our discussion. At 27 years old, multipara, 10 weeks pregnant lady presented with excessive and intractable nausea and vomiting. She is 27 years old, multipara, and 10 weeks pregnant, and she presented with excessive and intractable nausea and vomiting. On examination, mildly dehydrated and non-icteric. The liver functions, they reveal bilirubin normal, ALT 110 units per liter, AST 90 units per liter, and alkaline phosphatase 100 units per liter. So these are the liver functions of this lady. LT raised, AST raised, bilirubin normal. So the question is, what is the most probable diagnosis? You write down the most probable diagnosis with you, and we shall see whether you are right or you have done some mistake. And the second question will be, how will you treat her? So, a lady, 27 years old, multipara, 10 weeks pregnant, excessive and intractable nausea and vomiting, and these are the liver functions. Bilirubin normal, LT raised, AST raised, and these are the 2 questions. The answer is Hyperemesis gravidarum. She is in the first trimester, and the most likely chance in the first trimester is that of Hyperemesis gravidarum. When we diagnose a lady, pregnant lady, that she is having the Hyperemesis gravidarum, there's a set diagnostic criteria for that. Number 1, there will be severe or protracted nausea and vomiting. So such lady will present to you with severe and protracted nausea and vomiting, leading to, number 2, dehydration, electrolyte abnormalities, and laboratory markers of starvation such as ketonuria. And there will be loss of at least 5% of the pre-pregnant body weight. So the triad of the diagnostic criteria, severe or protracted nausea and vomiting, which leads to dehydration, electrolyte abnormalities, lab markers of starvation such as ketonuria, and loss of at least 5% of the pre-pregnancy body weight. We know that Hyperemesis gravidarum occurs in 0.3 to 3.6% of pregnancies. It usually develops in the first trimester, as in our case, and is a clinical diagnosis after excluding other causes of nausea and vomiting. Risk factors for Hyperemesis gravidarum include multiple gestations, as in our case, molar pregnancies, and fetal abnormalities such as hydropes fetalis and trisomy 21. Hyperthyroidism is another risk factor for Hyperemesis gravidarum. So we learned that it occurs in 0.3 to 3.6% of the pregnancies. It usually develops in the first trimester, and it's a clinical diagnosis after excluding other causes of nausea and vomiting. And the risk factors are multiple gestations, molar pregnancies, fetal abnormalities such as hydropes fetalis and trisomy 21, and hyperthyroidism. Jaundice is rare, as in our case, bilirubin was normal. Serum aminotransferase levels elevated in more than 50% of patients hospitalized for Hyperemesis gravidarum, typically 2 to 3 times upper limit normal, as it was in our case, but can be elevated up to 20 times even. Severity of nausea and vomiting correlates well with the degree of liver enzymes elevations. Higher the enzyme levels, high and severe is the nausea and vomiting. It's good that fulminant liver failure has not been reported in Hyperemesis gravidarum. This is a good point. Liver function abnormalities usually return to normal within a few days of volume expansion and cessation of vomiting. So once the dehydration is treated and vomiting is stopped, the liver function abnormalities, they return to normal levels. No long-term sequelae of liver dysfunction has been described. The cause of hepatic dysfunction in Hyperemesis gravidarum is unclear. We don't know why. The possibilities are starvation injury to the liver, release of inflammatory cytokines by the placenta, and impairment of fatty acid oxidation. Probably these are the 3 possibilities which leads to hepatic dysfunction in Hyperemesis gravidarum. Treatment is symptom-based. Intravenous hydration, correction of electrolyte abnormalities, nutrition, and antiemetics. In the most severe cases, parenteral feeding may be necessary. Serum urea and electrolytes should be checked daily, and maternal body weight should be monitored. The pregnancy unique quantification of MSS score. This is one score. Pregnancy unique quantification of MSS score. It's a validated system based on 3 parameters which can be used to monitor progress. These parameters include duration of nausea, number of vomiting episodes, and number of dry hues in the preceding 12 hours. And depending upon these 3 parameters, the score is calculated and it can be used to monitor the mother progress. Different antiemetics has been used by the different societies, like the Royal College of Obstetrician and Gynecologists criteria, then American College of Obstetrician and Gynecologist criteria, and EASL, the European Association for the Study of Liver. As in the first line, according to RCOG, antihistamines, which includes promethazine, cyclazine, then phenothiazines, which includes prochlorperazine and chlorpromazine. When these fails, then metoclopramide, domperidone, and ondansetron are used. When these fail, then corticosteroids has been tried, initially hydrocortisone IV, then prednisolone orally with clinical improvement, and then you taper dose gradually until at lowest maintenance dose that controls the symptoms. According to American College of Obstetrician and Gynecologists, the first line therapy is pyridoxine, vitamin B6, alone or in combination with doxylamine. If this fails, the second line drug is dimenhydrinate, diphenhydramine, prochlorperazine, and promethazine. And when this fails, the third line is then metoclopramide, ondansetron, trimethobenzamide, only recommended if dehydration is not present. And when the third line fails, the fourth line is chlorpromazine, methylprednisolone orally or IV for 3 days, and taper over 2 weeks to lowest effective dose. If beneficial, limit total duration up to 6 weeks. While the EASL suggests as a first line, pyridoxine B12 alone or in combination with doxylamine, just like ACOG. And then the second line is the dopamine agonist like metoclopramide, phenothiazines, or chlorpromazine, then the prochlorperazine, anticholinergics, diacylclavirine, antihistaminic, and cyclazine. And the third line here is the ondansetron and glucocorticoids. So the last resort glucocorticoids have been used in treating the hyperemesis gravidarum. So these are the 3 world societies, and they mildly differ by using the first line, second line, third line, and the American College of Obstetrician and Gynecology, they have kept the even fourth line drugs as well. So you can find these in the guidelines, but the point is that the mainstay is to control the emesis and the vomiting. Prognosis. What's the prognosis in this condition? Poor weight gain in hyperemesis gravidarum is associated with fetal growth restriction, preterm birth, small for gestational age babies, and low Apgar scores. Maternal complications are uncommon and include vernix encephalopathy, which presents with confusion and nystagmus. Hyperemesis gravidarum typically resolves by 20 weeks gestation, but may, in rare cases, persist throughout the pregnancy. There are no long-term consequences on liver function, and this is a good point. And recurrence of hyperemesis gravidarum in subsequent pregnancy is common, as in our patient, she was multiparent. So I end here. In the next vlog, we shall see the case history number 2. I hope in today's discussion, you have understood the hyperemesis gravidarum, how to diagnose, what are its symptoms, what are the liver function abnormalities in this condition, how we proceed, how we treat these conditions, what is its impact on the pregnancy, on the mother, and on the fetus, and what's the prognosis, and what are the risk factors for hyperemesis gravidarum. So I stop here. Be with me. In the next vlog, we shall discuss the case history number 2. Thank you very much.